I'm going to talk to you for a little while about what's happening in the NHS, and I'm sure all of you keep yourselves really up to date on the NHS, because don't you find that it's changing every day at the moment. Every single day there's something new. And luckily for me, as I'm putting these slides together, they don't need to go through Zinc or whichever form of approval that you all have. So I was able to go into it last night and put a couple of extra things in that came down the line yesterday. So hopefully it's up to date. Other companies I've worked for, we put into Zinc 6 weeks before, and then by the time I deliver it, it's out of date. So let's hope that this one is up to date. So even though we're saying let's have a look at what's happening in the NHS now, am I okay stood here? You okay there? I thought we'd have a little look back to 1948 of Nye Bevan and how he set up what his vision was. It was about looking at the state of the UK and all 4 countries at the time and saying we need to access healthcare, all of us, no matter where we live, no matter how much money we have, and it should be free at the point of access. And those guiding principles still really exist today. However, if you then compare 1948 UK to 2012, this is an Itzy Mori poll of 2012, and you actually look at the differences of the demographics in this country, it really isn't any wonder that the NHS isn't sustainable. Because we had a population back then of 43 million. This slide actually says we're up to 60 million, but we know that we're up a little bit higher than that now, aren't we? The over 65s back in 1948 made up 11% of the population. Now, over 65s, or 2012, it was 16%. But you know, some of the CCGs, health economies that you work with, they're forecasting an over 65 population of up to 50% and slightly over. So no wonder there is this change in how healthcare needs to be delivered. Our life expectancy back in 48 was 65 years. We're now up to 78, but there are parts of this country that still have a life expectancy of around 68 to 70. So when you're working with your populations, your local populations, it's that type of information that's really important when you're thinking about interacting with your customers. Knowing what their elderly population is, what the demographics are locally, is hugely important to them and to you. Our BMI back in 48 was 23. It's now up to 27 and growing. In fact, Diabetes UK in the 5-year forward view, they put in some information around diabetes, and they said that we in the UK spend 10 billion on diabetes now, and that's rising. And some of that is around this rising BMI. The NHS budget back in 1948 was 437 million. We're up to 110 billion now. So you can see, looking at the demographics, thinking about the population, thinking about the model of the NHS, it's not sustainable. And actually, these are the reasons put into context. We do have an ageing population, we know that, but with the ageing population comes this changing nature of disease, because we know that about 70% of the budget in England is spent on people with long-term conditions, 1 or more long-term condition. So if that's how the money is spent, and one of your products doesn't fall into one of those long-term conditions, how do you engage? What is it that's going to really turn them on to talk to you? Because there are other things that are important. It isn't just about long-term conditions. And this nature of changing of disease, there's also parts of the country, and I'm sure you're all aware of this, we have parts of the northeast that have a real issue with children with rickets. But we do have parts of London that have real issue with TB. So if you know that you're working in those areas and you're a commissioning manager in a population with rickets or TB, some of your money, some of your allocation has to go to A, treating those patients, but B, think about how do you prevent it. So again, in context for your product, you need to have that information at your fingertips so that you can engage more credibly. But there is this growing information age and advances in treatment, and all of you sitting in the room have got advances in treatment, but that comes at a cost, doesn't it? But we do have a changing workforce. The GPs that are coming through the system now, I think we're up to about 70% of them are female. And if that's the case, a lot of female GPs don't want to buy into a partnership, a GP partnership. They want to have salaried and sometimes part-time work. So there is a change in this workforce as well that's driving some of the decisions in the NHS. And us as patients and public do have much higher expectations. So all of this really drives the system and the demands on the system, but yet we know there isn't any more money going into it. But there are also now, and actually if I just flip back to this one, this is any modern healthcare system. This isn't just England, Scotland, Northern Ireland, Wales. You can actually put this in Germany, into America, and they're facing the same pressures on their systems. But if we think about us and in the UK, well, there is less money in our system. There hasn't been a cut in the budget for the NHS as there have been for other public sectors. But we know that there's less money in the system and the money needs to be spent in a more valuable way. We now know this 20 billion Nicholson challenge has gone, hasn't it? We're now looking at this 30 billion funding gap. We'll have a look at that in a moment. But we know that Simon Stevens is saying there is a gap of 30 billion. By 2021, if we don't stop that gap, if we don't plug that gap, then again we're facing an NHS that may become bankrupt. There is a massive variation, and I'm going to show you some figures around variation, and that still exists. Who watches that programme, 6 billion in the NHS? I think it's on the BBC Two programme. And they talk a lot in that programme about postcode prescribing, don't they? They talk about where you live will determine which access to which medicines you get, or not just medicines, to equipment as well. So there is this massive variation, and Simon Stevens, Jeremy Hunt are calling for that to be reduced. There is this huge waste, and there always has been. I was a nurse a very long time ago, 1985, so that was a long time ago, and there was waste in the system then. We had a lovely new ITU suite built in the hospital that I worked in. We all moved in, and then we all had to move out again because they forgot to lead line the walls. And in ITU you have to have daily x-rays, 2 hourly x-rays. They forgot to lead line the walls. So we had to all move back out, and the money had to then be reinvested to put lead lining in the walls. So waste is really rife in the system. We do need to think about transformational change, and you've probably heard about these new models of care. We're going to look at those as well. But this system has to really, the only way it can be changed is through massive transformational change. And we're going to see some of that as we move into the next couple of years. But we do need to think about increasing productivity. And productivity isn't just about how we spend the money better, it is about how do we get more out of that system. How do we stop patients going into secondary care when actually they can be cared for in primary care? Or how do we change that whole system, because that's the productivity challenge. You may have seen this slide, but I just wanted to think about why there is this gap in funding. Now this is quite an old slide, but it's still really relevant and explains quite nicely why we do have this gap. So from 2006 right up to 2010, the Labour government injected huge amounts of cash into the NHS, and we knew, I was selling at the time, I was in pharma selling at the time, we knew there was money in the system. We knew that the organisations had this money, but we also knew at the end of 2011 it would stop. And they told us it would stop. So right the way through to 13-14, there were no more cash injections. But if you look at these here, this is the demand on the system. So the cash stops, but the demand carries on. And the demand being the patients going into the system, not just because of inappropriate referring, but also because we have a growing population, we have an ageing population. So the demand carries on. And then the top figure are the running costs, because we know that running costs go up every year. So it doesn't make a mathematician to work out if you have the same amount of money, increasing demand and increasing running costs, there's a gap. And David Nicholson identified that gap back in 2010. When you read Simon Stevens' 5-year forward view, he does say, actually, in some ways, we've reduced that gap. We actually have stopped it, but now we've got another one. And we've now got a 30 billion gap. So actually, we're just rolling over, aren't we, to another funding crisis. So this was the Nicholson challenge. I don't think we've called it the Stevens challenge. I think we're just calling it the funding gap. So the 5-year forward view, he has said by 2015 there is this funding gap of 30 billion. And what he asked for, which was interesting, wasn't it? For those of you that read the 5-year forward view, it was published in October last year. It was the first time such a publication came from the NHS to the politicians and said, this is the state of the NHS, this is what it looks like, and this is what we need. Now it's up to you to respond. It's not happened that way before. And what Simon Stevens called for, with his colleagues from across the other organisations, we need an 8 billion cash injection into the NHS if we're going to save it. And an 8 billion cash injection over a phased time. So not straight away, but a phased time. So in the autumn statement, there was some extra money that came in. And again, we'll have a look at that. So the politicians, as we're leading up to May the 7th, they're thinking about how do we plug this gap. Now, I've had a look at quite a lot of the manifestos. None of them are saying they're going to put huge amounts of money. They're not saying we'll give you the 8 billion. They are saying we will increase. Some of them are calling it a mansion tax. Some of them are calling it a time to care fund. So there is some rhetoric in there, but we'll have to see what happens after May the 7th. So the story so far, and I just wanted to highlight this. The Commonwealth Fund, looking at 11 modernised countries, actually ranked the NHS in England as #1, which is quite interesting, isn't it? Because all of the media would tell us we have a dreadful NHS. But the Commonwealth Fund, in the 5-year forward view, said the NHS in England ranks the top. So it's a really interesting thing. And I think that's something maybe politicians should be publicising to the rest of the public. Because here are some of the results that over the last 15 years we've seen the NHS improve on. Early deaths from heart disease are actually down by 40% over the last 15 years. That's a staggering success, and I think really it should be celebrated. Cancer survivals are at their highest ever. Waiting times for operations are down from 18 months to 18 weeks. Now we're seeing them creep up again, but actually they are down significantly. And avoidable deaths are down by 20%. So that's the good news. Let's have a look at the finances, because that, for us, as we're working in it, it's quite difficult, isn't it? This is taken from NHS England's Q3 report, because obviously we're not at the end of Q4 yet. But what they said in the Q3 report is that around 10% of CCGs have forecast a year-end deficit. When I talk to some of our colleagues who work in CCGs now, and we've got 2 coming today, so we'll be able to ask them, they've actually said, yes, we forecast a deficit for this year, but because of what's happening with the tariff, which we'll look at, we're actually forecasting a deficit already for next year. So they're under huge pressure from a financial perspective. More than 4 out of the 10 trust directors are saying they really don't think that they will come in, and they're forecasting an overspend by the end of this year. NHS England has set the ending deficit, the year-ending deficit, by 184 million, and specialised direct commissioning is 120 million of that. So the contribution of direct commissioning into the deficit is, total specialised commissioning is 120. There's huge figures there, but yet we're still crying for more money. And we do know that value for money and how they're spending their pounds that they get is really important. But this is the backdrop that your customers, that you're going to see every day, are facing. So their minds are filled with this. Sorry, can you see? Their minds are filled with this. They're not really filled with your product. However, if your product, your offering aligns to how they could look at this and reduce this, then that's what they'll be listening to. So they've identified 3 widening gaps in the 5-year forward view, and this is where the variation is really staggering. So these 3 gaps are funding and efficiency, health and well-being, and care and quality. These are the 3 gaps that Simon Stevens has talked about. But these figures underneath are really quite staggering. As I said to you, I shared with you earlier that I was in the NHS a long time ago. We knew these figures back then, but we knew this happened. So if a patient is admitted into hospital on a Saturday, they're 11%, the mortality rates are 11% higher. If they're admitted on a Sunday, it's 16% higher. than if they're admitted on a Wednesday. So it's that variation that is so huge that I think you're right to think about specialised commissioning, but when you've got figures like this, that's really what's at the forefront of some of your commissioners and your providers are really thinking about. How do we stop this widening gap of variation? That's the hospital. In CCGs, there's up to 30% variation from CCG to CCG in health-related quality of life for people with one or more long-term conditions. Up to 30% is an awful figure, and wherever you live will determine those outcomes, those quality outcomes for you. So that's the variation that your customers are facing and they need to address. So that was the 5-year forward view, and then our annual planning guidance that comes out in December every year, as you're aware. This year was called Forward View into Action. So Simon Stevens and his colleagues have really thought about, well, if that's what it is, if that's what the NHS are calling for, let's just think about that and put that into action. I'm really sorry for a horribly busy slide, but I've got to just summarise it into some bullet points. So the 5-year forward view, the forward view into action combines the mandate, the constitution, and the 5-year forward view into action. You do have the funding allocations in there, so all of your CCGs know how much money they have to spend already. They know about that, but it also took into the autumn statement. So we know how much money is in the system. There is a dreadful turmoil around the tariff, and that's one of the things that I put in last night, having had another good read about what it looks like. Good for all of you is that last year's strategic operational plans can remain as they are. They don't need to rewrite them this year. They just need to think about, they need to review last year's outputs and just amend them as necessary. So if you were working with a CCG and you knew what was in an operational plan, it's going to be carried forward into this year. So that's great news for them and for you. There is intense focus on maintaining the performance indicators, so the NHS constitution, our waiting times, there's still massive focus on that. And the provider and commissioner really must work together on those assumptions and planning guidance. So they really have to come together. There's a real drive on that this year. So I said to you that there was some money injected around the autumn statement time in response to the 5-year forward view. It was 1.83 billion was injected with a 200 million investment fund for the transformational change than the new models of care. So there's money behind transformation for this coming year. I like this term. There's a permissive approach, again taken straight from the document. There's a permissive approach to developing and implementing care. I heard somebody describe the other day that this is almost, the NHS is open for business. If there is a model of care that your CCGs can present to NHS England and they can show outcomes, predicted outcomes, then really they're saying, actually, we want you to success and we will give permission to look at new models of care. There is now one national leadership team made up of the national bodies. So Simon Stevens, the Monitor, NHS Trust Development Authority, CQC, they are coming together to really form one national body. So hopefully we'll see this continuation of breaking down organisational boundaries from the top. So the priorities that were set, there's not that there are no new priorities, there were few new priorities for this year. Intense focus on meeting the NHS constitution. We've had some really bad press, haven't we, about the 4-hour wait and some waiting time. So there has to be a real intense focus, and again there's some real drive around urgent and emergency care. So new models of care around that are being introduced. Still, the outcomes framework is driving activity. There have been 1 or 2 minor tweaks on some of the indicators behind the domain, so I'd really urge you to have a look at them if you're aligning your messages to those, so have a think about them. There is this huge emphasis on national patient safety, and I keep getting alerts through from different organisations around conferences for patient safety. And as part of that, there are 2 new national indicators in sequence, one around sepsis and the other around acute kidney injury. So there's some national drivers now. the pressure sore ulcers have moved into the standard contract. And I've got another slide on sequins for you. But there's also a primary care quality premium indicator around antibiotic prescribing. Again, it's been in the media, hasn't it, antibiotic prescribing. There's now a QP on that. And lastly, this moving towards parity of esteem for patients, clients with mental health conditions. They really should have an increased access to physical health checks and physical health and well-being as those that don't have mental health conditions. But there's also some information or some new indicators around access to mental health consultants. So patients having a first psychotic episode has to be seen within 2 weeks of referral. So there's almost a parity of the cancer 2-week wait, isn't there, for patients with severe mental health. Hi Jackie, come on in. Don't worry. Come and sit down. Come and sit down. So these are the new priorities for 2015-16. Nothing huge compared to last year, some tweaks. So there's some stability almost within this new, direction of travel. So in the summary, there is this new national leadership body, 6 bodies. There is this radical upgrade in prevention. So this prevention agenda is huge, and there's some Public Health England will be taking responsibility for that, really thinking about prevention in a more formal, structured way. So prevention of not just of disease, but of admissions, of progression of disease. So again, if your messages align to the prevention agenda, really think about what your customers would like to hear. There's partnership working and breaking down organisational boundaries, and this isn't just between primary care and secondary care. This is obviously mental health and physical health. It's around health and social care. But also when you read the document, it's around general practitioners and consultants. It's really going down to grassroots levels as well as the top. So really having to break down these silos. We've heard it for a long time. Let's hope that it does actually change this time. They do talk about bridging this 30 billion funding gap, building on the improved outcomes that we've already seen, but I really wanted to focus on this new models of care, because this is going to change, potentially, how you interact with some of your customers. So these 3 models of care, how many of you have been seeing this emerging? How many of you are aware of what's going on out there? Yeah? So there are some new acronyms for us, aren't there? We love that. More acronyms for us. This first one being MCPs, so multi-speciality community providers, meaning that we're coming together, that moving specialist care out of hospitals and into the community. This could see GP practices, CCGs taking on consultants as partners. It can see specialist nurses coming in, physios, OTs. They're coming together to look at a model of care that's right for their locality. So there isn't a template for this, there isn't a blueprint. But if you want to have a look to see those that have been awarded this site, all their presentation videos are on the NHS England website. Started to watch one last night, but I fell asleep, so I'm very sorry about that. It was good, but it was late. So, so if you want to, I'm going to show you the list of where they've been awarded. If you want to know what specifically they're going to focus on in your area, then the videos are on NHS England. So MCPs are here. We've also now got this new acronym of PACS, so primary and acute care providers. This is joining up hospital, community and mental health services. And when you read the document, if you read what the forward view into action says, it could be that a secondary care provider offers primary care services. If you're in an area where actually the primary care services are breaking down and they can't employ GPs, it could be that the provider sector take that over and say, we will provide primary care services, GP services. Again, the videos are all online. And then lastly, there's enhanced health in care homes. That's not an acronym, so I don't know that we could get one out with that. Maybe that's a challenge for us today. What could we call this one? So this is really thinking about if in your area you do have an issue around the health that's being delivered in care homes, and you can see how that can be improved, working together with local authority to think about offering older people better joined up health, care and rehabilitation services. And behind all of that, the programme is supported and backed by this 200 million transformation fund. So all of the areas that have been given the status, Vanguard status, which I'll talk to you about in a moment, there will be funding behind it to support their transformation of models of care. Next slide is a little bit busy because it gives you the names of all the sites. So I'm sorry about that, but you can go onto NHS England website and find this. So PACS, there are 9 areas that have said yes, we will deliver a PACS service. So from Wirral, Mansfield, Yeovil, Isle of Wight, I think they already do to be fair, but that's because I live down that way and I'm sure that actually they do have an integrated system over there. But they presented to NHS England and they've been awarded a PACS site. For MCPs, here's the list here. So there are 14 areas in the country that have been awarded MCP. And there are 6 that have said that they are delivering enhanced health in care homes. So there's money behind it, they're transforming how they're delivering care in these areas. So if these are target areas for you and your companies, have a look at those videos and think about what it is that they're trying to achieve, see if there's something you can align to. These are probably going to be more likely to work with you because they are the forward thinkers. Now at the top I put Vanguard. They've been awarded Vanguard status. However, in one of the documents and one of the colleagues that I work with, he's told me that actually in the letter they said we're no longer going to call them Vanguard, we're going to call them Forerunner. So I just put it in there in brackets in case you hear that terminology. Some people are saying Vanguard, I think that's the majority, others are calling them Forerunner sites. So just be a bit aware that they might be something different. So I wanted to look at funding allocations. These have been set. So your CCGs, on average, they all know their funding allocations. The average increase was 3.4%. So, but admin budgets have been decreased by 9.7%. There's a real issue there around the management costs of CCGs. Their spending on commissioning and buying the services has increased slightly, but their admin costs have gone down. So that's a problem and they need to work with that. NHS England budget has decreased by 13.7%, which again is interesting to think about. If that's your area, if you're working at NHS England area team level, then we know that their budget has decreased. But don't forget, some of the services are moving over back to CCGs. All commissioners have been told to set aside a 1% non-recurrent spend to invest in this transformation. So even though there's money behind those that have been given Vanguard sites, money needs to be pulled out, 1% of their total budget. The Better Care Fund should be reviewed, so we've got to look at what their plans were in 14-15 and think about what do we need to do as a response to our Better Care Fund. I just wanted to go back to this, when we talk about mental health, if you do work in the arena of mental health, then each CCG has to make sure that they increase their investments into mental health by the amount of money that their CCG has been awarded. So if you're in a CCG with an increase of 3.4%, hi there, they need to increase their spend on mental health total by 3.4%. So it's not that there's extra money for mental health, CCGs need to invest more of their budget into mental health. So again, that's a challenge to them. They need to move money from somewhere into mental health. In the funding allocations, you probably know this, the tariff, the NHS tariff, every year is refreshed, isn't it? And for the last couple of years, it's been reduced by 1.9%. This year was no different. So the road test came out, the allocation, the funding around the tariff had reduced on average, well, totally by 1.9%. All of the providers, the majority of providers said, we can't take this on again. So there was a complete no vote, a no confidence vote, and they said, no, we're not taking this tariff. Now that's terrible news for Simon Stevens, isn't it? just as we're coming into a general election, the NHS tariff system looks like the wheels have come off completely. So we need to bring something in very quickly to make sure from April the 1st, commissioners and providers know how much they're paying and how much they're receiving. So that tariff communication has been absolutely rife. And if those of you that subscribe to HSJ, you've probably seen quite a lot of the communication backwards and forwards. And as I said, so those Vanguard sites were announced yesterday. That's what I put in last night for you. But also, I had a really good reread to find out what's happening about tariff. And this came out 2 days ago. So we've got 2 more acronyms for you, ETO and DTR. So 210 out of the 241 trusts have said and accepted the ETO, which is the enhanced tariff option. What that means is they are going to take the 15-16 tariff, the one that has a 1.9% deflation, but that's going to be enhanced by 0.3%. So it's a total deflation by 1.6, sorry. So they're going to take that. But there will be some local negotiation with their commissioners as well. Under this one, the sequence carries on. So for the few providers that have decided to go for the DTR, which is the default tariff rollover, they're going to take the 2014-15, so this current year's tariff, and they're going to stick with that. But they don't get sequence payments as a result. So your commissioners and providers are in turmoil, and actually we've talked a lot about breaking down organisational boundaries. This has actually just put some more issues up in front of commissioners and providers. There has to be some negotiation locally around this tariff. It isn't fixed in stone, however there was a deadline of the 4th of February for them to say to opt into this or not. This is what it stands at the moment. That's what's on NHS England's website right now. But I know, talking to one of my colleagues who works as a commissioning pharmacist, this has thrown their CCG into deficit already for 15-16 because they can't take on this extra money. It's around 500 million that wasn't budgeted for at the beginning of this year. So CCGs are really struggling with this tariff. Providers are also struggling. This is the backdrop for you to go out and sell. So we need to have this and we need to understand it. So if you do get drawn into a conversation, you can quickly answer it or you can defer it. But this is what's at the forefront of their minds. It's complicated, it's not set in stone. That's the best explanation I could get for you. Is that okay? So, just thinking about sequins. Sequins is carrying on for those under ETO. This is what the sequence looks like. So the minor changes on the 2 around, and I hate the word, delirium care, the dementia and delirium care, but there's a few tweaks that's staying as a national indicator. Physical health for people with mental health conditions is now a national indicator, so you can really see this emphasis on mental health conditions and patients with mental health problems. 2 new indicators around acute kidney injury and identification and treatment management of sepsis within secondary care. So they're the 2 new indicators. Providers and commissioners do need to think about improving urgent and emergency care and have a discussion as commissioners and providers about what they're going to be doing to reduce this crisis in their area around emergency care. The safety thermometer and the friends and family test has now moved over to the standard contract. So it's no longer a national indicator, it's moved into the standard contract, and that should be published, I read on the website last night, this week. But sequins do remain at 2.5% of the total contract value. CCGs around co-commissioning, you probably know a lot about co-commissioning already, but 64 CCGs have said yes, they want to take on co-commissioning, they want to take on the commissioning of primary care. It could move and it could expand to specialised commissioning. We only need to consider Greater Manchester and that model, and we can see that the face of commissioning, the landscape of commissioning is really changing. So those that were announced, there's a real divide across the country of those that have taken up co-commissioning. The Midlands and East area, region, have actually got 42.6%. Again, there is a list on the NHS website that you can find out who in your area has taken on co-commissioning and whether they've taken on fully delegated or joint. And that's really important. The 5-year forward view has driven this year's planning guidance, which was really interesting to see, which is now called the Forward View into Action. 1st of April is the first day of the coming financial year. This goes into action there. Great focus on prevention, or greater focus on prevention, patient empowerment, looking at the local communities and what your local communities need. New models of care, these vanguard sites, they've been announced. No major changes to the CCG plans. Carry on with the CCG plans, just think about what you've come in on at the end of the year. Funding allocations have been made, but these tariff discussions continue and co-commissioning continues. And 64 of those have taken on co-commissioning. We do need some more clarity around co-commissioning and how that's going to progress.